You're listening to Admitting Diagnosis, also known as Clinical Conversations sometimes, the Journal Watch podcast for March 13th. I'm Joe Elia, and you should call 1-617-440-4374 to leave us a comment or a suggestion. Both are much appreciated. We'll take a quick look at the week's news and then launch into an interview. This time, it's with Dr. Cheryl Bushnell of Wake Forest, whose team just published a piece in BMJ on the association among pregnancy, migraines, and cardiovascular complications, in particular, stroke. But let's meander through the clinical headlines of the past week. BMJ published two interesting pieces online. The first is the subject of our interview, and the other is an international stock-taking of how parenteral drug errors happen in ICUs. The research encompassed over 100 ICUs in 27 countries, including the U.S., and it found, among other things, that such errors aren't rare, that they usually occur during the daily routine and not, as you'd guess, during crisis times, and that they are easy to avoid if you're methodical about it. Next, the European Heart Journal advises that paying attention to blood pressure in diabetics with atrial fibrillation can reap big benefits. The number needed to treat to prevent one death was 39 in these patients. The NNT in hypertensive diabetics without AFib was over twice that, 84. Next, it's one thing to screen for existing breast cancers, but what are the best ways to estimate risk? The Journal of the National Cancer Institute says that age, race, and family history offer only modest accuracy in estimating risk. Risk estimates are improved, they say, if breast density is taken into account. Also, in counseling about reducing risk, it's worth mentioning regular exercise, weight loss, and a reduced alcohol intake. And in high-risk women, chemoprevention with tamoxifen or raloxifene is another discussion worth having. Now, on to the interview. Last week, BMJ published online a case control study titled Migraines During Pregnancy Linked to Stroke and Vascular Diseases. The cases were some 34,000 women whose hospital discharge summaries showed pregnancy-related ICD-9 codes and migraine-related ICD-9 codes. The data were collected from a national database of hospital stays. The controls were women whose summaries contained pregnancy-related codes but no migraine codes. When the authors compared the two groups, they found a 15-fold higher likelihood that the migraineurs would also have codes indicating stroke. They also found that the likelihood of hypertension codes increased 8-fold with migraine, and myocardial infarction rates doubled. It's important to keep in mind that coding is imperfect and inconsistently done, but still something's going on here, and we've asked the study's first author, Dr. Cheryl Bushnell, to talk with us about it. Dr. Bushnell is an associate professor of neurology and the associate director of the Women's Health Center of Excellence at Wake Forest University Medical Center. Welcome, Dr. Bushnell.
Thank you.
You found these women among some 18 million pregnancy-related discharges between 2000 and 2003. So let me ask a procedural question. Were the diagnostic codes always from the same patient over that period, or from a single hospital stay?
Well, that's an excellent question, and what we do say as a limitation of the study is that it is possible that we could be counting the same person who is hospitalized multiple times with a migraine discharge code, and the reason is because migraine is really more likely to be a chronic condition, but it is given precedence of either a primary or secondary discharge diagnosis to even be included in that discharge summary. So we think that the migraine codes are definitely an important and relevant code assigned to that particular discharge summary, but it could be that the number of codes we see could actually be repeat admissions for the same person. For the acute stroke and acute MI diagnoses, usually those are just counted once.
Okay.
Because they're an acute condition.
So over this period, then, you were looking at individual hospital discharges, and these things were clustered within that discharge record?
Yes. Basically, it starts with a pregnancy-related discharge code, and then from there it is whether there's also a migraine, and then the jointly associated codes, which may or may not have been during the same discharge.
Okay.
And so, again, it's the nature of database codes and the administrative database that we're looking at that we cannot really say cause and effect, and we don't know which came first, the migraine admission or the stroke admission, or any of the other vascular codes that we found associated with migraine.
Okay. Well, these conditions are relatively rare during pregnancies, aren't they?
They are. We had done an analysis of 2000 and 2001 specifically to examine stroke-related discharge diagnoses in the same kind of database. And at that point, we found an incidence rate of 34 per 100,000. And that's all stroke types combined.
Mm-hmm.
And again, that's the advantage of this administrative database, is that you can examine relatively rare diagnoses in a population that you can define based on these pregnancy codes as well. So it's a very powerful way of looking at rare diseases.
And your interest as a neurologist then started with the migraine end of it.
Well, actually, we started with the stroke analysis and found that migraine had a very, very high odds ratio. It was about almost 17-fold increase in migraine in the women who had stroke-related discharge codes.
That's from the earlier study.
Yeah, that's the earlier study we published in 2005 in Obstetrics and Gynecology.
And so you found this.
My colleague, I'm sorry.
And you found the reverse to be true then.
Exactly.
Yeah.
And that was what prompted the look at migraine and say, well, what are the vascular and non-vascular codes that might be associated with migraine? And it turns out that the majority of the jointly associated codes really were vascular, and almost nothing non-vascular was related to migraine.
Huh. So what other lines of research in this area are you and that group pursuing now?
I'm especially interested in the relationship of preeclampsia with migraine and with stroke.
Yes.
Because preeclampsia is really a vascular disorder. I'm not sure how many people outside of obstetrics and gynecology really know this, but preeclampsia is a risk for stroke later in life. So women who've had preeclampsia during pregnancy, the way to treat preeclampsia is to deliver the baby, but the vascular abnormality persists. And so it does increase the risk of stroke later in life. And I'm also interested in the relationship between migraine and preeclampsia. And preeclampsia, when it becomes severe, and they're usually hospitalized and are being monitored for any new symptoms, when they start to develop a severe headache, which could mimic a migraine, plus visual aura or scotoma, little spots and peripheral vision. Mm-hmm. And this is a signal that preeclampsia has been to the severe stage, and they frequently will go ahead and deliver. So you can see that there's similarities clinically and symptomatically between severe migraine and severe preeclampsia. So I think that there's something happening there, and then stroke is sort of in, if you imagine a Venn diagram with overlapping migraine, stroke, and preeclampsia, there's something to that, and I'm interested in studying the physiology of that from a cerebrovascular approach.
And it seems like a lot of this research right now is not so much bench-based, but database-based, isn't it? And so are you doing a fair amount of database programming to tease out these results?
I'm not sure that we can do much more with this same database. I think we need to work with prospective studies with clinical So actual patient-based research rather than administrative. This is a great start. It allows us to generate hypotheses, design studies to answer some of the questions that are raised with the database analysis. But the next step, from my point of view, is to start looking at actual women and doing some very simple studies of their vascular function to see if we can identify what might tie all of these diagnoses together.
I see. What would you tell a patient and a physician to do differently in the light of your findings so far?
Well, I think it's important to reassure most women that when they're thinking about getting pregnant and they know they have migraine headaches that come and go or even are chronic, that many women actually have an improvement of their headache during pregnancy. So the only women that I would probably counsel in some way or another are the women who are continuing to have severe migraines during pregnancy, because these are the women that we selected out based on this database analysis. Mm-hmm. Because they're probably we know we underestimated, because 185 per 100,000 deliveries is a severe underestimation of the number of women with migraine during that age range, childbearing years.
Yes.
So it's a select group of women with severe migraines active during pregnancy, and those are the women where I would be really concerned about their blood pressure, about the risk of developing gestational diabetes, smoking, any of the risk factors that we found associated with severe migraine really should be treated, and prenatal care is essential.
I see. And so that would be your advice to clinicians as well, then, is to be more aggressive.
Yes. Yes.
About treating these risk factors and watching these patients.
Right.
Okay. Well, Dr. Bushnell, I want to thank you so much for your time today. This is really interesting stuff.
Well, thank you very much. It was a pleasure.
Finally this week, some fan mail. I'm not certain what the caller is saying, but that's the fault of my phone system, not the caller's speaking talents. The message seems to be not to change our name from admitting diagnosis to clinical conversations. Give a listen.
Joe Elliott, I'd like to be called. I've been a listener of your podcast for over probably 6-7 months now, and I'm going to be an intern in internal medicine and clinical conversation. I don't know who keeps on giving me suggestions to change the name of the podcast. I think admitting diagnosis is one of the most catchy and best medical podcast names out there, and I really love your podcast. You have a personal it's more personalized in a sense, and you and the General Podcast are one of the top, most favorable podcasts to me, and thank you.
Okay, what do you think? Call and give me some clues at 617-440-4374, like this brave soul did. I won't necessarily use your comments on the podcast, but I might. Clinical Conversations executive producer is Adoriano, and I'm Joe Elia, asking, does the clue bus stop here? We'll see you next week. Meanwhile, be healthy and help others to get that way.